Hi, welcome to Doc Talk Live. Dr. Goodman, Dr. Sultan, Dr. Parvez Sultan. He is a cardiothoracic surgeon, and I am in his office, and we've been trying actually for a while to get together, talk about cardiothoracic surgery. You know, today I did a live surgery in the knee, surgery. Wow. So I know that you're anxious to give us a live surgery sometime as well.
Yes.
So hopefully we're going to do that. In the meantime, though, I thought we would talk a little bit about what is a cardiothoracic surgeon.
Yeah.
So let's start there.
Yeah, that's a great question. A cardiothoracic surgeon is a surgeon who's trained to do anything inside the chest cavity.
Okay.
That includes the heart valves, coronary artery bypasses, lung surgery, lung cancer surgery, esophageal surgery, and also sometimes the big vessels like aneurysms of the chest, aneurysms of the necks, carotids, and thoracic aorta. We do all of those. So we are trained, and this is a long training process. It takes 7 to 8 years to train to become a cardiothoracic surgeon.
So when I think of cardiothoracic surgery, I think of splitting open the sternum, cracking it open, and doing heart surgery.
Yes.
That's what I think of when I think of cardiothoracic surgery. Yeah. Tell me about that, sort of what that is, and then how this has evolved.
So, traditionally, that's what we were all trained, right? When we went to medical school, the old-fashioned way, when I went to medical school, they would crack open the chest, do heart surgery, very painful, and that's what we learned. Even in my fellowship, most of the stuff at Barnes Jewish Hospital, where I did my fellowship, we did all open sternotomy, open thoracotomy surgery. But now it has evolved in the last 10, 15 years to all of the stuff going minimally invasive, meaning you're not cracking open the chest. We're still doing valve surgeries through small incisions, and we do also lung surgery through small incisions, like 8 millimeter incision using the robot. We can do valve surgery using the robot. We can do valve surgery using small, minimally invasive instruments without ever cracking the chest.
So that's what I want to get to, is this robot. I think you enjoy using the robot.
Yes.
Is this like Star Wars, or are you in another room? Or how does all that work?
It's not like Star Wars. Initially, the technology was developed to do battlefield surgery for robots. So the surgeon can be on a plane away from the battlefield or in a base and do surgery in Afghanistan or other places. But what it has evolved to, I'm still in the room in US. We're still in the room or in a control room next to the room. There has to be a bedside surgeon or a PA who helps dog the robot. But I usually come in, put the instruments inside the body, make ports, and then I go and sit in the robot console and start doing the robotic surgery.
So because you're using a console, you're able to do things with smaller incisions. You don't have to get your hands in there.
My hands are nowhere inside the body. And also the flexibility. See, my arm can only move 180 degrees, but the robot arm can move 360 degrees, right? Mm-hmm. So I have better flexibility, better dexterity with that. And also the visualization is amazing in robot, because it really, the camera is very powerful. You can focus on the area that we are working on, and it looks much enlarged, and so it helps in dissection.
Now you have a video you can show us on your cell phone,
yes,
is that
yes,
right?
Yes.
Okay, so this is in lieu of live surgery, which is what ultimately we want to do. In lieu of live surgery, we are going to try to do this, show a video. Okay. So go ahead and tell us what we're seeing here.
So this is a robotic lung surgery using the Da Vinci robot at St. Vincent's. So here you're seeing robotic arms on the right side, and the left is basically dissecting the lower portion of the lung. This is an upper lobectomy. On this left side of the screen, you're seeing the heart beating.
That's the heart, okay.
That's the heart beating inside the pericardium. And this on the right side is the thoracic aorta. So you see it is in very high price real estate, a lot of important structures. However, with the robot, look at the visualization. You're looking at all the veins on top of the pericardium and veins and arteries on top of the heart. And then we are basically dissecting up into the lung. This is the lung on top. So we're taking the lower ligament that attaches the lung to the chest cavity. We're taking it out, and here you're seeing some of the like we call this cigar. These are basically retics, and that's what we put inside the body, just if there's any bleeding or hold up the lung without damaging them. This is just showing a couple of instruments that I'm using to get the lung down. And
Okay.
then the same instruments are used to dissect the portion of the lobe that I need to resect, or has the cancer, or is damaged, or need a biopsy. Then I go ahead and
Now,
and
is this
biopsy.
a lung resection you're doing?
This is a lung dissection for lung cancer.
For
yes.
lung cancer.
Yes.
And so, what is the? Do you remember what kind of tumor this was, or
This
what?
was, I think, a squamous cell lung cancer, which is one of the most common form of lung cancer in patients who are smokers. And look at here. Here we're dissecting down this area. What are you seeing? Is the lymph nodes that is being dissecting. I'm trying to get some lymph nodes. So it has tremendous visualization of the lymph nodes too. So you see, I'm trying to grab the lymph node, pulling it out, and so I get all the lymph node dissections done here.
Now, is this something that maybe you couldn't have operated on before? Has this increased your ability to reach certain tumors?
Yes, it has, but also it also has increased my ability to reach for smaller tumors, and the post-op care is day and night. The amount of time patients stay in the hospital after a robotic lung surgery is very low. They go home in 2 to 3 days, and compared to big incision where we used to do old-fashioned thoracotomy or cracking open the ribs, it takes a lot of time, and patients spend 4 or 5 days in the hospital. And also, look at the dissection, how precise it is. I'm using this robotic bipolar cautery, how precise it is, so there's very less air leak. There's another instrument on the left arm. So the right arm has the cautery, left arm has this instrument. See this instrument? Mm-hmm. It's called a curved dissector. So I'm holding the lung away from the aorta. So the aorta is beating. There's blood going in.
It's that big tube.
This big tube, that's the descending thoracic aorta, and it has blood going there through at a blood pressure of 120/70.
Jeez. You got any more videos for us? This is great anatomy.
Yeah, I know.
You pull them up on your phone.
We'll do some more, and hopefully we'll show you some live cases soon.
Okay, super. Let me turn this back around on us so it can see us. Awesome. So we're back. If there's any questions for Dr. Sultan, please ask them. If you're catching this on a rerun, please do it some other time. Just typing your questions, and I'll get Dr. Sultan to try to answer them offline sometime.
Yeah, absolutely.
So I can see where you're doing this minimally invasive stuff. What's the most common thing you do with the robot?
Well, I do a lot of robotic lung surgery. That's probably the most common lung resection and lung biopsies.
So how does somebody get to you with that type of problem? Is it I would think it would all be referral.
It's all referral, but sometimes we see patients who come into the hospital from the ER might have a lesion in the lung or a small lesion. They're sent to us sometimes, but mostly comes through pulmonary medicine, the lung doctors,
Okay.
or a cancer doctor who sees a lesion, who they're suspicious of it and they can't get a biopsy of it, they send it to us.
So now you're in a group of cardiothoracic surgeons, I would imagine. So do you guys divide up? Like I'm the guy who does lung with the robot, and I'm the guy who does the big open heart surgery and things like that.
No, we don't divide up like that. It depends on what is your interest. So we are all trained to do cardiac and thoracic, and we are very good at both. But then over the last 10 years, have developed very much interest, as you know, on robotic surgery, and therefore I went and got extra training. I was never trained during my fellowship to do robotic surgery. So after finishing fellowship, which is like 17 years ago now, I trained myself in practice, went to different courses that Da Vinci did, and went to certain surgeons who were like key pioneers of robotic surgery and learned with them. And so now I'm routinely doing it.
So is robotic surgery routine for the cabbages, the vessel
Cabbages,
things?
it is still very difficult to do robotic surgery. Some people do it, but cabbage is not. But on
valves.
valve surgeries, we do it.
So how do you decide between when something can be done? Everything is obviously done open.
Yes.
But some things are done with the robot. How do you choose between robot versus open?
So in thoracic surgery, 80 to 90% of my practice has become all robotic surgery for lung biopsies, lobectomy, and stuff. If the cancer is very big or there's a lot of adhesions, meaning from previous radiation or previous chemotherapy, redo operation, those I don't go robot because the adhesions are very difficult to sometimes take down. But I tackle plain old stuff simply through robot. In heart surgery, all isolated valves, like aortic valves, mitral valves, you can do robotic or minimally invasive, So we do all isolated aortic valve, mitral valve, tricuspid valve, all minimally invasive. Patients who have redo heart surgery or needs double or triple valve or valve and coronary, those you cannot do it robotically because it's more involved. So we need to open the chest and we have to because we have to reach the left side of the heart in those cases. On most of the other valves which we can access from the right side of the chest, which is like aortic valve, mitral valve, tricuspid, we can all do it from the right chest through small incision.
I'm going to throw you a curveball. Pulmonary hypertension.
Yeah.
A friend of mine was recently diagnosed with pulmonary hypertension, and a physician friend, and he says that carries a very poor prognosis.
Yeah.
Can you comment about pulmonary hypertension and what causes that? And
well, there are
is there anything you can do as a cardiothoracic surgeon?
As a surgeon, we can't do much unless there's a valve causing pulmonary hypertension.
So there's a backup.
Yeah, what is pulmonary hypertension? Basically, the blood flow in the pulmonary system is going higher.
Right.
So the increased flow through the pulmonary system. It's a low flow system, so once it goes higher, then what happens? The pulmonary arterial wall becomes thick and leads to pulmonary hypertension. Their primary cause, secondary cause. So sometimes valvular disease we see pulmonary hypertension, like mitral valve. So if mitral valve is leaking a lot, so the blood, instead of going to the aorta, is going back to the pulmonary left atrium and then to the pulmonary veins,
Mm-hmm.
It's going to pulmonary veins and pushing back into the pulmonary structures. And that leads to pulmonary hypertension. So if we can prevent the factor that is causing the pulmonary hypertension, the backflow of the blood into the lungs,
then you could do something.
Then we can do something. And I've done people with come in with a pulmonary artery pressure of 90, which is pretty high, which is as high as systemic blood pressure in some people. But when you fix the mitral valve, repair it, so that change the blood flow, then the pressure goes down immediately to like 40. That's amazing. But other causes of pulmonary hypertension, there are some causes that your surgery cannot fix it, and you have to use medicine. There are different medicines like pulmonary vasodilators you can use to kind of relax those arteries.
You brought up the mitral valve, so I have to ask because every specialty has what I'll call the mitral valve prolapse.
Yes.
Like rheumatology has fibromyalgia.
Yeah.
And urology has interstitial cystitis.
Yeah.
Comment a little bit about mitral valve prolapse, if you would.
Yeah. Well, mitral valve prolapse, is very common. Very common in women. Young women can get diagnosed with mitral valve prolapse. And basically what it means is one of the leaflets of the valve is ballooning out from the plane of coaptation of the valve. So valves usually close like this, but this is coming out like this. So there's a prolapse. Over time, what that means is there's more blood flowing, more blood flowing through that area, and it can go bad. So a young person who get diagnosed with mitral valve prolapse at the age 20 and stuff, nothing happens to them. But when they're in the 50, they become more symptomatic because now more blood is going the wrong direction. You understand?
Yep.
And that's when we fix. The most easiest thing to fix in mitral valve prolapse is P2 prolapse, which we resect it and repair the valve with the patient's own tissues, and it has fantastic long-term results.
That's awesome.
Yeah.
Well, let's see. Are there any questions? Let me just see if there's any questions. I think we're good on questions. Is it live? 4-4. Yeah, Ed, we're live right now. Sorry, go ahead.
Who was that?
He's Ed Beckman. He's a tennis.
Ed.
He's
Oh,
a
yeah,
tennis
yeah.
pro.
Oh, Ed, I know Ed.
Anyway, that was great. That's what I wanted to talk to you about. We do need to do something live in the OR. Any
Yeah,
other topics you want to hit before we say goodbye?
No, I mean, the lung surgery robotically has revolutionized this surgery actually. Unfortunately, a lot of people don't do it. In Alabama, there's only 2 surgeons who really do it routinely.
Oh, really?
Yeah,
Okay.
one at UAB and one myself.
Okay.
So we have the maximum volume of people who really want robotic lung surgery. They look for us through internet or through the word of mouth. They come to us, and therefore there's a big learning curve, obviously. So I can't just finish fellowship and start robotic surgery. It takes a while to get good at it. And I think that if you see the patients, next time maybe I can do a live program, and then maybe have a patient come and talk to us.
That'd be great. Yeah.
Who has had robotic lung surgery. So
Yeah.
that'll tell you and they'll show you the incisions.
Sure.
Which are tiny, like 8 mm incision.
Yeah,
less
that would
than,
be great.
so-
No, our audience would love to see that, and not only that, if we plan for it, maybe we can build an audience
Yeah,
so they know
yeah.
they know we're coming on at a certain time.
Unfortunately,
and-
as you know, we tried to plan a few times, we were
Yeah.
canceled because of the pandemic. But hopefully
yeah,
we'll do it
I'll
again.
give you an elbow.
Thank you,
Thanks,
Brad.
Parvez.
Thank you, Brad.
Thank y'all.
Thank
Appreciate
you.
it.
Bye.
Bye.